Take any time, you will straight will come to the first presentation, beta blockers and pilocarpine by Dr. Ganesh V. Raman. He need no introduction. I think he is so familiar with the KSOSP.
Thank you, sir. So you are familiar with me, and we are also familiar with beta blocker. So this is going to be very, back to school talk. Very simple. Thanks for the audience staying back late, and just a refresher course on beta blocker and pilocarpine. Pilocarpine more so mainly because it's on shortage. So the more time we get to read about it, and more we can appreciate its benefit. So propranolol was the first beta blocker which was actually discovered in 1967, and once it was discovered, they started using it for eyes also. They used to mix it and use for eyes. The problem was it was very toxic to the cornea, profound dry eye syndrome and subconjunctival fibrosis like cicatricial pemphigoid, very quick tachyphylaxis. So the effect will go off very quickly. Then timolol came into the picture and became a big hit since 1978. So reduces aqueous production up to 1/3. So these are all like the FDA trials. So they would take not very high pressure up to 32 millimeters mercury, and if you put a drop of timolol, you can get 1/3 the reduction. Onset starts at 2 hours and duration lasts for 24 hours. Virtually used for all forms of glaucoma. So this is one medication which you should be very familiar with. Used in all forms of glaucoma. Non-selective agents are timolol, cartiolol, levobinolol, metoprolol, and beta-1 cardioselective is bitoxolol. So timolol, it's a non-selective beta blocker. Without the intrinsic sympathomimetic activity, it reduces aqueous humor production by acting on the beta receptor, and no effect on the aqueous humor outflow. This is what we have to remember. Action of 0.1 and 0.5 is similar. And patients with dark iridis will require higher concentration. So that's why 0.5 has become in vogue. Otherwise, we'd be very happy using 0.1 only. And contralateral effect on the systemic absorption is quite significant. IOP reduction has been reported up to 20 to 35%. 5 to 10% of patients per year will develop tachyphylaxis. And if you want to discontinue, the effect lasts for 2 to 4 weeks. That means the washout lasts for about 4 weeks. It's like the washout of aspirin, which we stop for before surgery is, if you want to get rid of the aspirin effect, you have to wait at least 3 to 4 weeks. So 5 days of stopping aspirin actually has not much of a role. So it's just for our own consolation that we do it. But similarly, timolol also the washout effect, and that also depends on the color of the iris. So darker iris will require a lot longer period of washout than lighter colored iris. Adverse effect, local irritation on eye is not very frequent. You can have local allergic reaction, lid edema, allergic conjunctivitis. You have membrane stabilizing properties. So if you happen to stain your own patient with fluorescein, you will find that they don't complain so much. So you can use this as a compliant measure. So you can use it as a measure for adherence to treatment. So if he's not wincing, that means he's using the medication. And you can also have dry eyes and superficial punctate care. You have tachyphylaxis, which is long-term drift. So you have reduced effectiveness due to constant exposure of the drug agonist, and then you have short-term escape because the receptors get saturated, and there is a drug-induced upregulation has to occur of beta receptors, which may also occur within a few weeks, which loss of effectiveness. So what you do for this is give a drug holiday. You can give a drug holiday of about 2 days or 5 days for the receptors to come back and then start using the medication again. Coming to bitoxolol, which is a beta blocker with a relative specificity of a beta-1 receptor, it reduces aqueous humor production of 18 to 26 percentage point. Wise, and efficacy is lower than that of timolol. Available in 0.5 concentration, used twice a day. Contraindicated in sinus bradycardia, heart block, congestive cardiac failure, and cardiogenic shock. But we use this mainly in patients with ischemic heart disease and all, mainly because it doesn't have all the bitoxolol get used for blocking the beta-2 receptor in the eye, so it doesn't have much effect on the heart directly. Cartiolol is a non-selective beta blocker with intrinsic sympathomimetic activity, very weak agonist activity, IOP reduction of 20 to 32%, available in 1%, 2% solution. And compared to timolol, it has been shown to decrease HDL by 3.3%, whereas timolol can reduce HDL by 8%, and this can increase total cholesterol 4%, whereas timolol can increase 10% of total cholesterol over a long period of time. So this is something which you have to think of. Levobinolol and metoprolol. Levobinolol was available in India till recently. Some years back, it used to be sold by no financial interest here. It used to be sold by Allergan as Betagan. And this is again very similar to timolol. And metoprolol has been associated with granulomatous uveitis. So adverse effects of all these medications include burning, stinging sensation, congenital hyperemia, corneal anesthesia, punctate keratopathy, intraocular inflammation, allergic conjunctivitis, and dry eye symptoms, cicatricial pemphigoid. And systemic adverse effect quite significant. You can have depression in the CNS system, confusion, nightmares, psychosis. You can have bronchospasm, cardiovascular system. You can have bradycardia, hypotension, reduced myocardial contractility. You can precipitate a congestive cardiac failure in patients who have a predisposition. If they are compensated, this can decompensate the situation. And you also have reduction in exercise endurance. So for example, if a patient has a tendency to climb a flight of stairs for a period of time, that they may struggle to do that. And others, you have contraindicate myasthenia gravis and reduces glucose tolerance and masks the hypoglycemic symptoms of reduced blood sugar. So when you have so many systemic side effects, very important to make sure that systemic absorption reduced. So I always encourage the patients to close the eyes for 10 minutes at least after application of the drop. You can also practice punctal occlusion. Coming to pilocarpine, this was from the discovered first by Argyll Robertson and Sir Thomas Fraser in 1800 from the Nigerian Calabar bean. And this bean became a source of extracting physostigmine. So the very senior practitioners will remember Eucerin, which is actually physostigmine, very powerful medication because severe chemosis after application. And it's an important imidazole alkaloid. It's extracted from the leaves of Pilocarpus microphyllus, known in Brazil as jaborandi, and mainly for the treatment of glaucoma. So you have the cholinergic agonists, which are the direct acting pilocarpine methacholine. Indirect is demequarium, ecothiopate, physostigmine, neostigmine, used extensively in myasthenia gravis and other neurological conditions, and carbachol, which has direct and indirect acting. So direct acting has stimulation of muscarinic receptors on the ocular muscles to cause contraction. Indirect actually inhibits the acetylcholinesterase enzymes to elevate the endogenous acetylcholine levels at the motor end plate to cause the same effect. So it increases the conventional outflow. That's the mechanism of action. So it contraction of the longitudinal muscle of the ciliary body, pulling the scleral spur, opens the trabecular meshwork, reduces the US scleral outflow, and circular muscle contraction leads to accommodation, and meiosis occurs because the sphincter muscle contraction. The weak myotics are the direct acting acetylcholine mimicking drugs, that is pilocarpine. The strong ones, which I mentioned, Eucerin, they are quite strong. Drug delivery systems were developed to deliver pilocarpine. You had soft contact lenses, you had pilocarpine gel. I think Cadila was marketing it, no financial interest there. You had Ocusert, which was a membrane controlled delivery system also. So again, these can be used for most forms of open angle glaucoma. In acute angle closure glaucoma after reduction of the intraocular pressure or giving systemic treatment, this is a drug of choice. And even now for chronic angle closure glaucoma, we use this medicine. Not used in inflamed eyes like neovascular glaucoma, or phacomatous glaucoma, or glaucoma involving the corneal infections, congenital glaucoma, glaucoma with angle recession, malignant glaucoma. Systemic effects are quite numerous. Again, you have general weakness, fatigue, diaphoresis, salivation, bronchospasm, pulmonary edema. In cardiovascular system, you have hypotension, bradycardia. Anesthesia, you can have prolonged respiratory paralysis with succinylcholine. Ocular side effects are also numerous. You have meiosis, brow ache, accommodative spasm, have a tendency for retinal detachment to occur. So any patient on pilocarpine, at least once in a year, once in 6 months, please examine the retina. The intraocular pressure reduction could be because of retinal detachment rather than the effect of pilocarpine itself. So be very, very careful. Cicatricial pemphigoid, increased tear production, punctal stenosis, progressive shallow of chamber, even in open angle glaucoma. So now it's available as a fixed drug combination also with timolol. I think Dr. Meena Menon will be covering that. We have pilocarpine 2% applied 3 to 4 times a day. That's the dosage. Thank you very much for your patient listening. Thank you.
Ganesh Veeraman, do you have any idea why the pilocarpine is not available now?
Yeah, so it's a big story. The import license for pilocarpine is held by the Brazilian company. I'm at a shock to know why an import license for importing something in India should be held by a foreign company.
Okay.
So the import license got expired. So they were not bringing it into India. So nobody was having the raw product. Now what these companies have done, and the import license can never be, set right very quickly, because the process itself takes almost 1 year to get an import license for anything, let alone being, an Indian company. So what they do is they have now done something like artificial growth in the laboratory that's known as callus. Callus is the plant of the Jabrandi plant. They grow it in the lab. And from that, they're extracting, which they're doing in China. So the raw material coming for both the companies, one is FDC, other one is Kite Pharma, something like that in Delhi. Both of them are procuring their raw material from China. Even Orolab has got the raw material from China. They still haven't started. They started bottling it. They are checking out the quality and the other parameters. Then they'll release it into the market. But FDC started this early, so they're in the market now. That's the reason.
Pilocarpine, the additional indication coming out, presbyopia?
Yeah, that's again another indication, presbyopia, 0.125%. Allergan is coming out with that, again, no financial interest. But many people say the effect is short-lived.
Thank you, Ganesh. That was nice. Pilocarpine, by the way, is useful in open angle and closed angle.